Interventional radiologist. Great, so you can field questions too. Oh, there are patients. Yeah, well, okay.
Okay.
So Isha, you see, I am sitting over there to demo. Yeah. But these are the chats. You don't really need to ask them. Let them ask the regular questions. I think I've got it covered. Well, where's Patricia? Patricia can ask one question, which you can prompt. Okay, perfect. Let's see.
Real down. Okay, can everyone hear me? Is this on? Okay, perfect. All right, so I think we're going to get started and get straight into our next panel. We are talking now about fibroid and adenomyosis, multidisciplinary management, and who is on your team. So I'm so excited to present our panel. We have Dr. Morris to my left. Dr. Morris is an interventional radiologist at NYU Langone Health. She works with me at the hospital and in our Center for Fibroid Care, so we consult frequently on fibroid cases. So I'm very excited to have her. She can share some of our management that we do at NYU. We also have Joelle. Osias.
Yes.
Osias. 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 Beautiful. And she's going to be talking about vitamin D, suppression, disease prevention, and how we use nutrition and vitamin D. And then we have Dr. Mahmood Razavi, and he is at St. Joseph's. He's also an interventional radiologist, so we have 2 interventional radiologists on the panel. And then we have Dr. Carlos Simon. Dr. Carlos Simon and reproductive endocrinology. So we have a full panel of specialists, and we're going to be talking about multidisciplinary care. So thank you all for joining us. And I think we're going to start with our patient story.
What is this?
If it's not cancer, then it's just livable. We're going to talk about fibroids because obviously it was fibroids that kind of started all this momentum. What were some of your first symptoms of fibroids? When did you first know?
Oh, well, thanks for having me on. And hi, everybody. The thing is, I didn't know. In retrospect, I think the first symptoms were just like very heavy bleeding, like uncontrollable, like bleeding through everything, which is not fun. You can't go anywhere without like this big worry, and it's like, it's going to happen. So that was the first sign. I think the sign that kind of got me going in the right direction, but it took a few years, I had some like random sharp pains, like, and I was like, I've got to check this out. What is this?
Yeah.
And then they told me, oh, it could be fibroids, but they didn't say that it was a problem. It's like, okay, so I'm not dying. I don't have, the big C. You're good. So that was kind of it.
That was it.
That was it.
If it's not cancer, then it's just livable.
Yeah, you're happy. You're happy that you had these sharp pains and that you're not dying from it. So
Right.
No one educates you that it's a much bigger picture, or a much bigger topic.
Yeah. When you did go in and talk to your doctor about it, when you went for the first time, what was that like? What did the doctor say?
Well, here's the thing. I didn't talk to my doctor about it because I didn't know that I should talk to my doctor about it. And I would go like for my yearly exam, and they would put me in the ultrasound. They say, oh, it looks like you have some fibroids. Let's measure them. Now you're going to go to the doctor's office and talk to him. And then he'd say, okay, well, it looks like one looks a little big. We're going to watch it. And that was like year after year after year. So I had no idea that, the increasing difficult menstrual cycles I was having was due to that. Not let alone like the low energy and, horrible blood count. So I'm really happy that this conversation is happening because you want to hear other people's experiences. I feel like when I was going through everything I was going through about a year ago, that's all I wanted was to hear other people's experiences. I was so happy, not happy that they'd gone through it, but like I wanted to know what I was going through, like hear that kind of common ground of like, oh, okay, I understand now.
Yeah, that's actually just it. It's that idea of community that I think we all want. Like, you don't know what you don't know. Mm-hmm. And so without having that place where other people are talking about it, you're not really going to know what to ask.
It's true. And you definitely don't know what you don't know. But just by other people speaking about it, who knows? Maybe someone will see this conversation where they're like in their search in Instagram, and they'll be like, wait a minute. I don't have to feel this way. So this is the point of it all.
Yeah, we love the turning point. Like, what was the one thing where you were like, okay, well, now I know?
Yeah, the turning point for me was literally kind of what I just described. Like I was on social media and an ad popped up. I watch it and I'm like, wait a minute, that's me. Wait a minute, I don't have to live with this anymore, because it was just increasingly difficult. And I was just like, oh God, here we go again, and just you brace yourself. And I was just so excited. It was a weekend. I just couldn't wait for Monday. Like I was just in my seat waiting, like I can't wait to like call someone.
That's when we met, and that was really, I think that sort of launched kind of our discussions on this. And I think a lot of people have really benefited from hearing your story. So it's just been amazing. And so if you had to tell women, how best to advocate for themselves, or what they should do, what would you tell the next woman? What should she know that you wish you knew?
Oh, wow. What I wish I knew was more about what's happening in the female reproductive system, what's normal and what's not normal. Also, some of the things that can affect you that you should know about. Yeah. Whether it's ovarian cyst or uterine polyps, adenomyomas, where the fibroids are growing matters. So all those different things I wish I would have been educated on. So that way I would have known when my symptoms got out of control that I had a problem. I could have addressed my issues before I had to have a much larger surgery than I could have had I known years sooner.
Right.
So those kinds of things really matter. So I think for each woman, being able to educate yourself starts here.
And being able to advocate for yourself.
Yeah, being able to advocate for yourself is so important. You should be able to have a health solution that you're comfortable with. You should not feel like someone forcing something on you, if that's a treatment or not to have a treatment. Because it can be both ways, right? While someone doesn't give you options or they force an option. Yeah. You should be able to make those decisions in your own time. Sometimes it takes time to understand. But in order to be your own advocate, you have to educate yourself.
So true. Thank you for being an advocate for other women. Thank you for being, just so inspiring to so many women.
Yeah,
thank you so much for being here. Okay, so actually you guys got a sneak peek at that episode, which will air next Wednesday on Health Starts With Her, which is our YouTube channel. So it's at Health Starts With Her for anyone who wants to tune in. Okay, so I'm Dr. Shirazian. I'm going to talk about multidisciplinary and patient-centered care for fibroid disease. I'm the director of the Center for Fibroid Care at NYU Langone Health. So the issue at hand, which I think we've talked about a bit already, but maybe not in full detail, is that fibroids affect the majority of women globally. And the cumulative incidence is very, very high. Up to 80% of women everywhere in the world up to the age of 50 have fibroids. There is racial disparity in fibroid disease, so Black women are affected more than white women. And 20 to 50% of fibroids are symptomatic. Now, these are just reported numbers, by the way. So symptoms have been defined in a variety of ways. We say symptoms include heavy bleeding, reproductive issues, pain, urinary frequency, anemia. I don't really feel like we define symptoms as pressure, bloating, weight gain, those sorts of symptoms as much, because I do think that many fibroids are symptomatic of those 80% of women that are affected. Fibroids delay seeking treatment for over 3 years. Fibroid patients often see more than one provider, 2 or more, before receiving a diagnosis. So some of the history of fibroid disease parallels that of endometriosis, and often these diagnoses exist together. In fact, we see fibroids, we see endometriosis and adenomyosis all in the same patient. And so one surgery or procedure will likely not treat fibroids adequately for an individual patient for her whole lifetime. This is just a little bit more, again, sort of what I was saying, that patients wait many years before they receive a diagnosis, and often women are seeking out, these days especially, more and more treatments that are non-invasive, treatments that are uterine sparing, treatments that are minimally invasive. So we sort of need to meet this desire and need among patients for less invasive surgeries and procedures, and also procedures that preserve fertility. So at the Center for Fibroid Care, we consolidate specialties into one center of care. So our patients can come in and they can benefit from the expertise of a range of doctors. And we provide multidisciplinary care. We have monthly meetings. We talk about patient care as a group. We have IR, which you'll meet Dr. Morris. She's our interventional radiologist at the center. We have nutrition. We have mental health services. We have REI, reproductive medicine in-house. We have OB in-house. So we're able to rely on the expertise of a range of doctors. We also focus on research and public health and thinking through preventative strategies for women as well who have fibroids. We have a number of research projects currently ongoing. This is our website. So why are we unique? Well, I think we're unique because we're a model of multidisciplinary care. And by multidisciplinary care, I don't just mean surgical care or procedural care. I mean holistic management too. I mean nutrition. I mean mental health. I mean really prioritizing life goals for patients, which many patients have the same life goals: fertility, pain management, prevention. You know, every day I hear from patients, Dr. Shirazian, great, I'm excited we're going to do the surgery, but how can I make sure I don't need another surgery? Like, I don't want to be back here again in a few years, right? And recurrence is a really big issue with fibroids because we know there's a very high rate of recurrence. So building out these programs are, I think, very important across the country and even the globe. So multidisciplinary fibroid centers, there has been some published data on it. There are a handful that exists across the country that have published data. And it has been shown that they perform more myomectomies than any other type of procedure surgery. So a lot of patients will flock to centers when they want myomectomies and maybe have been denied myomectomies elsewhere, like they've been told they need a hysterectomy, and then they come into centers of care for those more complicated myomectomies. It's also been shown they offer more medical treatments. There's an increase in MIGS and IR specialists. So centers can really provide streamlined services for patients. Prioritizing shared decision-making is important, making sure patients are satisfied with their care, that they're heard. Those are all top priorities. We have a nutrition and prevention program that we've run for the last 6 years, and it really focuses on educating around nutrition, what sorts of nutritional elements can be important for fibroid disease. We talk about vitamin D, exercise, and curcumin, and potentially some of those protective effects. And we layer them into the care that a patient receives. So yes, a patient may need a surgery or they may need a procedure, but they should also layer in vitamin D supplementation, nutrition, exercise. What are all the tools that we have that can help the patient care the best? So our LIFE program, we've studied it and published on it at this point. Initially, we had 100 patients enrolled. We had a little over half of them complete the intervention. We had a very rigorous program where we asked them to exercise, we did nutritional supplements, and then we followed them with the quality of life survey, the uterine fibroid quality of life survey. These were patients who had had a procedure or a surgery and then were enrolled in the program for prevention. So they were not patients who needed surgery and instead had nutritional management. They were offered the program after they had any intervention. And we found that this was sort of a breakdown of that group of patients. Many of them had higher fibroid burden. They had more fibroids, so they really wanted to do everything possible to avoid another surgery or another procedure. Many wanted to be pregnant, and many reported improved quality of life measures over the course of the study. So every 6 months, they responded to a survey that asked about sexual function, self-consciousness, activities. This is the standard quality of life survey. And we found that there was improvement in those scores over the 2-year time frame. We also found that, the uterine volume did not increase. It had plateaued for those few years that patients were enrolled, again, doing the vitamin D, doing the exercise. So we felt very reassured that lifestyle measures could in fact benefit our patients. Their hemoglobin levels were good, their vitamin D levels rose, and we saw that these quality of life measures did improve. So now we offer it to our patients who are interested in a nutritional program in addition to other management. And comprehensive, well, I'm gonna skip that one. So the research that we're currently have ongoing focuses on a few different topics. This is one that I wanted to just show you. We have developed some patient-provider dialogue scripts for physicians. So we're trying to improve the counseling around fibroids. And I don't want to go through.
In scenario 3,
So how do I back
Maria is a 28-year-old patient with asymptomatic fibroids found incidentally during a CT scan that she had done for abdominal pains. And the CAT scan shows some fibroids, but she doesn't have any symptoms that bother her. So she is coming into you today with the results of that CAT scan.
So this is meant to
Hello.
show
Hi.
sometimes how we brush off patient concerns,
So,
and then also how we should address patient concerns, all in the same video.
That's what brings you in today.
Yeah, I was at my general doctor and I was having some stomach pain, and so they sent me to go get a scan, and it looks like I might have fibroids.
That's what happened. Okay. Yeah, I think, the primary care doctors and even the generalists, they like to send people for CAT scans. And so sometimes the CAT scans will pick up some small fibroids. No big deal.
I'm having some anxiety just knowing that they're there. Is there anything that we can do about it?
I mean, it's really small and I don't really think it's going to cause a problem for you. I don't think it's why you have abdominal pain. So
it's meant to mimic what patients hear, right? So this is what they hear from their doctors. It's no big deal. You don't need to do anything. And so then can you fast forward this? I want to go to,
Is there anything?
TikTok. I mean, TikTok.
so these are,
I also did some other research that said that something called a UAE.
so this is sort of the bad way to respond to patient concerns. Okay, let's go midway through it, since I know we don't have a lot of time. Okay, yeah, no, like halfway through the video, just to show a little bit of, so in the same video sequence, it shows then
Scenario?
how to appropriately address fibroid.
In scenario 3, Maria is a 20.
All right, we can't do it, unfortunately. But in the second half of the video is how you demonstrate hearing what the patients say, even if they're talking about TikTok, how to acknowledge TikTok and say, I understand there's a lot of good, information on TikTok. Let's review what you've heard. So it's meant to be scripts. We're getting them CME approved, and they will be available to providers of care, nurses, NPs, emergency room physicians, general GYNs. I think those are our target groups that we would like to help educate around counseling. Counseling is a true art form. And we did a lot of focus groups around the counseling of patients. And we learned many things about, how difficult it is sometimes for physicians to have the time to perform, good counseling. So we wanted to offer scripts that would facilitate and encourage, shared decision-making and active conversation. This is actually a quote from one of the MIG surgeons in one of our focus groups. And she was saying, we really can't be dismissing patients' concerns. She felt very frustrated that, patients are not being heard and wanted to sort of be part of that solution. So definitely, I think surgeons and doctors overall want to hear concerns, but they don't often sometimes they may not have the tools to best do that. So that is our goal with these scripts. And we learned that, like, our generalists often felt uncomfortable counseling about newer medication. They often felt uncomfortable putting patients on progesterone. I literally had a few different GYNs tell me, well, if they need progesterone, then they need to see you. And I'm like, I don't know that people need to wait and see me to get norethindrone or to get a basic medication, right? I think that results in delays in care. So
it's about educating all groups so that we improve access overall. Clinicians reported comprehensive fibroid management, but found that barriers, discomfort, and attitudes limited the practice, essentially. So this is an educational intervention that we've been working on. We sort of said that. And the last one I wanted to talk about for a moment is a research study we're doing on fibroid access, care, and treatment. It's a multi-center study, so we are doing this survey along with 4 other centers of care. And the idea is that we want to identify barriers to care and treatment access based on various factors. We want to understand the patient experience around their symptoms, around their experience with other doctors, around their diagnosis, decision-making, and the emotional impacts of fibroid care, because we've heard from many patients that they've seen 3, 4, 5 different doctors. So the goal of the survey is to capture all of that in a way that's more objective. So we can basically report on it and let people know that, patients are experiencing this across the country, and these are the things we need to work on to be better. So we hope this will inform more equitable, responsive fibroid care. Our prelim data has shown that almost half of our patients saw 3 to 5 clinicians before seeing us, that 67% had reported never discussing reproductive goals, so that was not part of their conversations with their doctors and surgeons prior to coming. They reported high stress, and a diagnosis, 62% were treated or referred to a specialist, and only 33% went untreated. So we learned a lot from our initial survey data about what women have been experiencing across the country. And we do see women from all over the country. So we're a center of care that has the ability to kind of collect this data and report out on it. So it is definitely one of my big goals. So I would like to implement our model of multidisciplinary care across the country. I want to create formal treatment and prevention counseling guidelines for providers, like we were just talking about, and I want to study access disparities nationally. So these are some of our goals as a center, and we're going to keep pushing the envelope, pushing forward, and doing more research on these topics. Thank you. Next up is Dr. Morris. I don't know if it's the same.
Good morning. Thanks so much for having me. My name is Liz Morris. I'm an interventional radiologist at NYU. I work with Dr. Shirazian extensively at the Center for Fibroid Care, and I'm very excited that this audience has welcomed me here as an interventional radiologist, and let's get started. So the goals of today's, let's try to get started. Let's see. See. Oh, there we go. So the goals of today's talk, we're going to be talking a little bit about what UAE is. I heard mention in the previous session about HIFU and ablation. We really do UAE for the most part, but I'd be happy to take any questions at the end about other techniques that we do to take care of women with fibroids and adenomyosis. How does UAE fit into your practice? What patients are right for this procedure? How can we collaborate to best take care of our patients? And then I'll do a quick case presentation of a patient. So as everyone in this audience knows, there is a huge burden both on the patient and society caused by fibroids. Tremendous quality of life issues related to fibroids. Our patients really have, really it affects every aspect of their life, personal, professional, bleeding symptoms, bulk symptoms, fertility issues. The economic burden of fibroids is tremendous, and interestingly, is driven primarily not by treatment of fibroids, but actually missed work, which is a huge issue that really goes undiscussed with these patients. So these patients are really suffering, and they are hungry for options, and they really want to hear all of it from their doctors. And traditionally, unfortunately, they have not been counseled on all of the options available to them. And so increasingly, there's more and more dialogue to really allow patients to hear their options and have more agency in selecting what fits them in that moment. So currently, the treatment landscape for fibroids, all the way from medical therapy through to more invasive surgical management of fibroids. And uterine artery embolization basically fits somewhere in the middle. It's a uterine preserving technique. It's minimally invasive. It's an endovascular procedure. Therefore, I go in through the blood vessels and I do all of my treating from inside the blood vessels. And it addresses all of the fibroids and adenomyosis in a single session. So it's not a targeted technique, one fibroid at a time, but I think of it more as a global treatment of the uterus as a whole. And in recent years, we're gaining more and more acceptance from the gynecology community, which is wonderful. And in 2021, ACOG came out with a very declarative statement recommending UAE based on level A evidence for the treatment of fibroids. So what is a UAE? So again, it's minimally invasive image-guided endovascular procedure. We use this technique, this kind of umbrella technique, to address a variety of issues. Fibroids, most commonly, adenomyosis, adenomyoma, AVMs, postpartum hemorrhage, preoperative embolization, palliative embolization. And then basically within that umbrella of UAE, there are nuances in the techniques that we employ to basically target those various conditions. So how do I do a UAE? So my patients are sedated with moderate sedation. I do not use an anesthesiologist unless there's some sort of issue that requires it. And the patients are just sort of sleeping on the table and they have no memory of having been in the room. I get percutaneous arterial access. I prefer radial access. And so you can see here, it's a radial sheath. It's very slim and that's it. That's my entire incision. No scalpel, just a poke. And that sheath that's in our patient's wrist basically gains access to the patient's arterial system. So under fluoroscopic guidance, I get my instruments down the arm, down the aorta, and into the pelvis. And from there, we delineate the pelvic arterial anatomy, get a lay of the land, see what the patient's arteries look like, make sure everything lines up with what we're expecting based on our preoperative imaging. And you can see here, this is an internal iliac artery angiogram. You can already see those hypervascular fibroids. Those are those big circles there. The fibroids are very thirsty. So even from the higher up pelvic arteries, we see those thirsty fibroids drinking up the IV contrast that we're injecting. From there, we identify the uterine arteries, we get inside of the uterine arteries, and we inject there. And again, we see that very hypervascular, we call it tumor blush in other parts of the body, but this is fibroid blush. It really brings in the contrast, very avidly enhancing. And so once we confirm that this picture looks like what we're expecting, then we can start to inject those particles. I use Embozine, that's what's shown here. They are calibrated to different sizes. I use 700, 900 micron particles typically for my procedures. They're made out of acrylic. And they are permanent agents, and we use those permanent agents for the fibroid and adenomyosis patients. So why does UAE even work? To understand why UAE works, we have to understand why fibroids cause these problems. So fibroids and adenomyosis in periuterine contractions, they increase the endometrial surface area. So if we can shrink the fibroids with a UAE by causing that ischemia, we can lead to symptomatic relief. Smaller fibroids and adenomyosis mean better uterine contraction to control menstruation. Smaller fibroids and adeno mean less surface area of the endometrium to shed during menstruation. So what we're looking for here is selective fibroid adenomyosis infarction while preserving uterine perfusion. And so how can we accomplish that? How can we just get the beads to go to the fibroids and not to the rest of the uterus? So like I mentioned before, fibroids are very thirsty. And so they're tumors, they're benign tumors, but they have this tumor physiology, right? So they're very thirsty. They steal blood from adjacent structures. And we take advantage of that preferential flow toward the fibroid to guide our procedure. So we can see under fluoroscopic imaging that's going on throughout the procedure that the fibroids become saturated with those beads. And we know at that point, once the fibroids are saturated, we conclude the procedure. The myometrium is able to recover. It has a redundant blood supply. And again, the preferential flow is toward the fibroids, not toward the myometrium. And so what we see on our post-procedure imaging, when we get an MRI, usually at about the 6-month mark, is we have black holes where the fibroids used to be. They're completely devascularized, and nice, normal, healthy perfusion to the remaining uterus. So this is just an example from a patient I did last week that kind of exemplifies what I'm trying to explain with how we kind of guide the procedure toward the fibroid. So this is a coronal T2 image of the patient, and it's the last thing I like to look at right before I walk into a case. I like to have a snapshot of what that patient's fibroids look like, so I know when I go into my case that what I'm seeing angiographically lines up with what her anatomy looks like on an MRI. So the images on the top are before embolization. You can see that fibroid blush. You can see those arteries kind of taking on that rounded appearance that we see in the MRI. After we've injected the beads, you see a persistently filling uterine artery, but all of those fibroid arteries have been pruned down and are no longer filling. And that's when we know the procedure is done. So this is a different patient, but this is what it looks like on an MRI after 6 months. So I saw this patient recently in the office, very bad bleeding and urinary symptoms. We see on the pre-procedure imaging, the post-contrast MRI, lots of fibroids, avidly enhancing, large uterus. And after the procedure, we see black holes where those fibroids used to be, but preservation of that enhancement of the entire uterus. So the fibroids lose the perfusion, the myometrial perfusion is preserved. In this patient, we got a 57% volume reduction, which is about what we expect. And the fibroids are smaller, they're also softer. So it just makes a lot more room in the pelvis for the things that need to be there. So what patients are ideal for UAE? Where does this fit into your practice as gynecologists? We treat patients with bleeding and bulk symptoms. We have to consider the nature of the bulk symptoms, make sure what we see on the MRI lines up with their symptoms, and that we can achieve with a 50% decreased size the goals that they have. Patients are interested in uterine preservation. They don't want to have their uteruses taken out, and we can avoid surgery with this. We treat fibroids, adenomyosis, also mixed fibroid adenomyosis patients as well. Multiple or solitary fibroids are all fine. Any anatomic location is satisfactory for a fibroid embolization. I like to make sure that my patients aren't too keen on getting pregnant after the procedure. And then another role for UAE is that patients are maybe poor surgical candidates. Maybe they can't have anesthesia or they're on anticoagulation, and those patients can avoid the OR with a UAE. So when is UAE not ideal? Like I mentioned, we have to see those fibroids enhancing on MRI. So we need to know that they're thirsty. If they're thirsty enough to absorb the contrast during the MRI, then they're going to be thirsty enough to take up those beads during the procedure. If they're thirsty, then I've got a lot to work with. Some fibroids have already degenerated before the patient has come to see me. Those patients are not going to benefit by having their fibroids further devascularized. They're already devascularized. Some fibroids, very, very, very rarely, I don't know if I've seen one of these in 5 years, with a very narrow stalk, almost like a lollipop. We want to avoid those because we worry about those coming off. Obviously malignancy, infection, again, fertility, I have a slide later on that. If you're very keen on getting pregnant, I don't want to do a UAE on you. And anaphylaxis to contrast. Mild allergies are fine. I have done UAEs on patients with severe anaphylaxis to IV contrast because it was necessary. Nobody likes to do that. So complications, what really happens to these patients that we need to look at after the procedure? Most commonly is pain. This is not a complication. This is a reality of what happens when fibroids lose their blood supply. There's a big spectrum after the procedure, what happens, but I plan for the worst and hope for the best. Realistically, it's 2-3 days of bad pain. We send patients home with really good medication regimens to get them through those first few days, and then they really turn the corner. Post-embolization effects, malaise, fatigue, low-grade temp, just kind of feeling a little run down, very normal byproduct of cutting off the blood supply to the fibroids. Uncommonly, I've listed some other complications. The most common of the uncommon ones I get is a little bit of bruising around the wrist, and you can see a picture of a patient there. So fertility and UAE. My stance on this, I've read every article there is on the topic. None of them are particularly good. But there's a clear trend toward harder time getting pregnant, harder time staying pregnant. And increasingly, we're starting to see some more data that suggests increased rates of postpartum hemorrhage and accretive spectrum disorders. So that's how I counsel my patients. You'll see a picture here on the right. The bottom image, there's a big fibroid and a very normal uterus. That's an easy no-brainer. The picture up top is a little bit more challenging. You know, these patients are between a rock and a hard place. The fibroids themselves are causing fertility issues. Treatments for the fibroids can cause fertility issues. So these patients just need really good multidisciplinary counseling. And I think having REI and IR and GYN all in one place is really helpful for these complex patients. So the big question, how does UAE hold up to the other treatments we can offer? There have been multiple large, well-designed randomized controlled trials that show that UAE is safe and effective and really on par with a lot of the surgical alternatives. Quality and life benefits, symptomatic control on par with surgery, patient satisfaction on par with surgery, reduced recovery time. The big caveat is there is a higher reintervention rate. This is about 15% in the first 2 years. It has come down significantly in recent years, but that's about where we're hovering these days based on the most recent data. So what can our patients expect? Great symptomatic improvement. This is really a phenomenal procedure for a lot of women. Fibroids shrink about 50%. We counsel patients. There's no hospital stay. They recover for a couple hours and then they go home. And most are back to work within 1 week. And again, that reintervention rate is about 15% in the first 2 years. So by working together, we bring in more patients for better quality care. And I really do believe that. This is a picture from our website. I'm very proud to be sandwiched between 2 gynecologists. I think it's a lot of progress for us as interventional radiologists to be a part of the dialogue and really offering patients really true multidisciplinary care. If you want to counsel a patient about a UAE, who better to counsel that patient than the person who's performing the procedure? So we all want the same thing. We want to collaborate to give our patients the best level of care. So the highest level of care to the most patients. We want happy, healthy patients. We all want that. And let's get them in the door and give them the options that they're really craving. So let's do a quick patient example in the last couple of minutes that we have here. So this is a 47-year-old woman. I followed up with her recently in the office. Very bad bleeding symptoms as well as some urinary bulk symptoms. She was not able to tolerate the myfembree due to side effects. She's a very active woman. She's a veterinary tech, so physical on her feet, and also works as a jiu-jitsu instructor. Her bleeding symptoms were really life-altering. She could not work a full day without bleeding through her clothing. Again, a very physically active, very fit woman, and really debilitated by this. Also urinary frequency, which was significantly impacting her quality of life. Here's her preoperative MRI. You can see here, these are post-contrast images. All of those gray circles within the uterus are those enhancing fibroids. There's a sagittal image on the left and axial on the right, and she's got about a 500 cc uterus. So here are my procedural images. Again, there's that coronal T2 image. I like to have the last snapshot before I walk into the room. That's what I'm working with. That's what I expect to see. So the images on the right-hand side of the screen are my iliac angiograms on the left. I start with the right iliac angiogram in this patient, and then we get more selective into the uterine artery, and we see that nice fibroid blush, and it looks a lot like the picture on the left. And then again, the bottom images, I do a left iliac run, and then again, we see the fibroid blush from the left uterine artery angiogram. So at the 6-month mark, I followed up with her recently. She had significant improvement in her symptoms. She was saturating through diapers before, having her period twice monthly, and now she's changing her pads 3 times daily, and her urinary symptoms have completely resolved. And we can see why when we look at this MRI. So those previously enhancing fibroids completely devascularized. The uterine myometrium remains perfused, and we've had about a 47% uterine volume decrease for this patient. So she had a great result. So the take-home message is UAE is a great procedure for a lot of patients. Make friends with your interventional radiologist. They want to be a part of the conversation. It's going to help your patients. It's going to help you to have an interventional radiologist involved. It's a safe and effective and underutilized procedure, and a lot of women are craving these minimally invasive techniques and could really benefit from it. And we get there with true collaboration, not competition, but partnership. And that's how we really have success with our patients. Thank you. If anybody would like to email me, my email there is below. And I really thank you for inviting me to participate today.
Thank you so much, Dr. Morris. Okay, next up, we have Dr. Osias.
Good morning, everyone.
Good morning.
Morning.
I'm Dr. Joelle Osias. I'm a medical director at Fibroid Medical Clinic in Menlo Park, California. I trained at Stanford University for my medical school education, and I was an intern when I met Dr. Najat. That's over 30, almost 35 years ago. And so he has had a tremendous impact on the trajectory of my career, and it's interesting to see how it's all coming full circle today. When he talks about endometriosis as a whole body disease, he told me that I was standing across from him in the operating room. And at that time, I didn't have the conceptual framework to understand what that could really mean. But today, you're gonna see how we're trying to actualize his vision for addressing endometriosis as a whole body disease and implementing standards of care that can be disseminated among, not only amongst patients, but among us as physicians, that we can also shape standards across the world. I think AI is going to be the tool that's going to allow us to do that and to be able to achieve his vision. So that's one of the things that I'm committed to actualizing. And on my team, I have my office manager, and I have a mutual patient that we treated, he was so inspired by the wonderful care that she received from Dr. Najat, and combined with the approach that we used in helping her to resolve her symptoms, that we decided to try to see how we could implement AI as a tool to improve patient care. So our objective not only is to streamline patient care for me as a provider, but also to see how we can be a small part of actualizing Dr. Najat's vision. And our hope is that this is going to be the catalyst that would help us actualize his vision on a larger scale. And I think it's possible because the technology is now available, but we definitely have the will to make that happen. So I'm going to start by looking at a different way of visualizing the care of patients with endometriosis. So if endometriosis is a whole body disease, as gynecologists, we're becoming more and more proficient in treating the disease surgically. We have a lot more surgical tools that are allowing us to do a better job and to provide surgical care and to minimize side effects. But one of the patient's unmet needs that we still struggle with is how do we allow patients to achieve symptomatic resolution of their pain? Because oftentimes we are not able to guarantee patients that if they have surgery to correct their anatomical defects or to take care of their frozen pelvis, does that translate into resolution of pain? And we see patients come back, and it's interesting now that I'm in the Bay Area again, that I see patients that Dr. Najat operated on with me when I was a fellow over 25 years ago that still come back to see him. And so we started to see, well, what can we do when the answer to patients' pain isn't surgery? What do we do to address the concern about getting symptom resolution? So I'm gonna challenge you to look at endometriosis as a systemic illness and to see what does that mean for us as gynecologists and how we can contribute to the resolution of the patient's symptoms and allow them to have a better quality of care. That's the next slide. Okay, so if we look at our perspective right now, so we know that it's a condition that affects the pelvis, and that's a manifestation that's most prominent, and we're very familiar with it. But the question then becomes, what are the other factors that impact the disease, and how can we modulate them? So currently we have access to therapies that impact inflammation profoundly, and so if we address inflammation, immune system dysregulation, as well as metabolic imbalances, we are able to influence the deterministic factor in the etiology of endometriosis and achieve a better symptom resolution. And if we harness those strategies as part of our perioperative and postoperative management, then we can achieve better patient outcomes, which means better resolution of pain, because pain by itself is not going to respond necessarily to surgical intervention and hormonal manipulation. It has to be, we have to look at the bigger picture in which endometriosis occurs and in which pain manifests itself. So I have developed an interest in the microbiome, and partially because a lot of patients with endometriosis also have irritable bowel syndrome. And so they have either diarrhea or constipation, bloating, and we're often familiar with the patients complain about endobelly. And what is endobelly really about? it really reflects a disruption in the lining of the intestines. So the intestinal barriers that have increased intestinal permeability, and that causes food to become an inflammatory trigger. And in the setting of inflammation and a disrupted barrier, then food then becomes a trigger for pain. And so my goal when I'm seeing these patients is to address the underlying causes of these immune dysregulation, and then to heal the gut. And that way they can have resolution of their symptoms. That means a normal bowel movement and no more pain when they eat. Some patients, for example, would tell me that they're not able to eat out at all because if they eat, they're so uncomfortable, they're not able to sleep. So that meant to me that I needed to take a closer look to the bowel and to gut and to see how we can improve that environment. So if we look at other comorbidities that we see in patients with endometriosis, we can see that they have a lot of dysregulation, not only, this is more they have also POTS syndrome. We see a higher incidence of Hashimoto's thyroiditis. We also see that they have other symptoms, like we have ADHD. I see a lot of patients with ADHD, depression, diseases that affect their entire body. So if we want to achieve a better quality of life for the patients, we have to address the other driving factors of their manifestation. So when we embark on our workup, we do a comprehensive evaluation that includes laboratory evaluation. So I look for thyroid dysfunctions. That includes doing the traditional TSH, free T3, free T4, but also look at reverse T3 and reverse T4, reverse T3, and as well as the antibodies that we need to screen them for autoimmune thyroiditis. We also do a thorough evaluation of gut function, not just looking for stool, ova, and parasites, but we want to look at the gut barrier. So we want to see if they have elevated calprotectin, do they have increased zonulin, do they have antibodies to gliadin, all those things let us know that they have inflammation that needs to be addressed in order for their pain to be better. So when we look at endometriosis, not just looking at their pelvic manifestation, we look at what's the bigger context in which that disease exists. So if we have a broader framework in which we look at the disease, we're more likely to achieve symptom resolution and have the patient experience an outcome that's meaningful to them. Because for a lot of patients, it can be very discouraging to have a wonderful, perfect excisional procedure, but to still experience pain. So my goal is to enhance that patient experience and to provide reproducibly good outcomes for the patient once they have completed their surgery, that they feel that they're being accompanied through their recovery, and that they feel that they have actionable information that can empower them to overcome and live successfully with their disease, so it doesn't define their existence. So in treating patients with endometriosis, I've had to learn how to repurpose drugs that were approved for other indications. One of the things you're going to hear a lot about is methylene blue. And now I think our current Secretary of Health, he was photographed on the plane drinking methylene blue, and I thought that was interesting. And Dr. Nujat uses methylene blue with every surgery to visualize the ureter, and we saw that demonstrated today. But it turns out that methylene blue has a lot of therapeutic benefits. One of them is that it's a mitochondrial optimizer, which means it helps with inflammation. It helps with the patients who need a bit more energy, and also helps with the bladder. It turns out that methylene blue is bacteriostatic. So a lot of patients who have interstitial cystitis and have pain in the bladder, methylene blue ends up being very helpful. I'm also using peptides. Peptides are becoming very famous now because of the preponderance of GLP-1s. A lot of people are using GLP-1s predominantly to help with weight loss, but it turns out that GLP-1s have pleomorphic impacts on the body. They not only help patients who want to lose weight, and they clearly help patients with diabetes. We're seeing that the GLP-1s are, by lowering inflammation, are also helping patients with endometriosis. So this is one of the therapeutic modalities that I've been using very liberally with patients with endometriosis with good results. And the patients, they don't mind losing some weight. But for those patients, we tend to microdose. So rather than using therapeutic doses of the GLP-1s, we were using smaller doses. So let's say if we took tirzepatide, which is normally dosed at 2.5 to 15 milligrams, I would use half a milligram. And that allows patients to have resolution. And so this is the GLP-1s. They affect the brain, the body, they affect every organ system. So I'm going to try to go through a little bit faster because I want to give time for our patient to talk to you about what her experience has been. The other thing that we've been using in helping the heal the microbiome is these are prebiotics. This was developed by one of my classmates, Roseanne Crystal, and she developed this to help her daughter who had long COVID. and it turned out that the microbiome is disturbed in patients with long COVID. And she was able to help her daughter heal with this prebiotic formula. So that helps us see that patients who have systemic illness, if we heal the gut, we're able to improve their clinical outcome. So this is Roseanne Crystal, and she's the one who developed that supplement, and her daughter went from being bedbound and unable to comb her hair, and now to be able to have a more normal quality of life. And the other therapy that we've been implementing is exosomes. Exosomes are basically the secretome for the stem cells. We're doing an IRB right now looking at exosomes for modulating inflammation for patient endometriosis. I'm going to have you speak to one of my patients who's here, Lily. She's going to demonstrate to you, talk to you a little about her experience has been with exosomes and some of the other therapies that we implement. So Lily, I'm going to summarize briefly, was, she had that severe endometriosis. Dr. Najat treated her. This is a picture of her pre-operative scan. She had a 12 centimeter dermoid, stage 4 deep infiltrated endometriosis. And after her surgery, she had persistent pain. And by implementing these therapeutic modalities that we were repurposing, methylene blue and other peptides, she was able to experience resolution of her pain. And Lily is pre-med, and now she's going to be taking the MCAS next month, and she's looking forward to really acing her exams. And that's been possible by repurposing these medications and looking at her disease from a holistic perspective. So Lily has also been leading the effort for us to develop an AI tool that's going to allow us to streamline our processes so that patients who come to us, we can incorporate Dr. Nishat's operative summaries, their clinical course, the regimen of the peptides that we're going to implement for them, and to create a roadmap for them to help them through their recovery. So my vision is to be able to use AI to help me to actualize Dr. Najat's vision for treating patients with endometriosis. We're going to be able to use the information that he has published in his textbooks, all the literature that he has already available in the literature, and to be able to mine that, to be able to customize the care for the patients that we're treating. So this is a team that we have right now, and for patients like Lily, it took her parents, us, a multidisciplinary team that includes my nurse practitioner, that I want to acknowledge, Amber, as well as Gabriella, who helps me in implementing a process, a roadmap for taking care of these patients. Lily, where are you?
She's right here.
Okay.
Right
Come on up.
here.
2.5 minutes, so you can maybe demo what you created.
Sure. Yeah, I'm Lily. Hi, I'm 26 years old. I'm from California. I have had endometriosis symptoms since I was 12 years old. I also had a bunch of other comorbidities that were kind of mentioned up there. Essentially, I was not diagnosed with endometriosis until about 4 months ago, and I had to demand an ultrasound. And every single other physician that I went to before for other treatments, I was always bringing different literature to them, different things. And something I noticed was I have an incredible amount of privilege for being educated in this, and that there's a lot of people out there that don't know what's going on with their bodies, and that's a really scary thing. And I think something that I had a hard time with was that once I had the surgery acknowledged, the turning point in my care was Dr. Najat looking at me and saying that your pain's not in your head. That has never been said to me before. That has never been validated. And it really just changed the way that I thought about it. I was told by other surgeons I would never be able to have kids. I would need a urinary bag for the rest of my life. And I just kind of sat there and was like, there has to be a better way. And there is. And I think that the other part of it was that after the surgery, it was so intensive. I had so many other high risk just comorbidities that my whole body was sort of destroyed. It's a systemic disorder that affects everything, including your central nervous system. And without that understanding, we can't fully treat the patients and actually get them better. And each woman is unique. I need something else that's different than the person next to me. And the way to do that is no doctor could possibly sit down with all of these patients and get their entire record and make sure they keep track of everything and know every single comorbidity they have and the implications, et cetera. So using this AI tool, we could possibly have our entire patient profile in here using their data to essentially have a holistic care perspective, as well as a lot of just very accurate responses. So I had my surgery in December. It was highly successful, but it was about 5.5 hours. So we're gonna ask this bot some questions and see what it comes up with. Aisha in the back has been working literally all day and night for weeks on this, and it is incredible. And I just really want to urge you to try to think a little bit outside of the box and realize that we need outside of the box solutions for this. And I think that is possible.
Woo!
I'm gonna just take a minute to demo Razavi. So this is our first, this is gonna be the patient companion that's gonna help to streamline the care. And our vision is to be able to use Dr. Nejat's, his experience to help us develop something that's gonna be more generalized, but this is first for the patient side.
Yeah. Yeah, okay. Do you want, is it gonna speak or do you want me to speak?
It's isn't just a gynecological condition. It's a systemic.
Here we go.
Hi there, I'm Lily. I'm so glad you're here, or as Dr. Osias says, forward we go. Endometriosis isn't just a gynecological condition. It's a systemic inflammatory disease that affects how patients feel every single day. After surgery, patients are often sent home with instructions, but not always with clarity. They're left wondering, is this normal? Why do I feel this way? Should I be concerned? And those questions don't happen during clinic hours. They happen late at night. Recovery isn't guesswork. It's clinical, dynamic, and deeply personal. That's why we built Lily. She understands your records, your labs, your medications, and helps you make sense of what's happening in your body in real time. So you're not guessing, you're guided. Let me show you. This is Lillian's Unified Care Hub. She's recovering from a laparoscopic excision, 2 active programs, endocare, recovery, and wellness. Every detail she sees comes directly from her care team. Lily indexed every document Lillian has shared. CBC results, metabolic panels, operative reports. Ferritin 18 and CRP 2.8 are the numbers that matter. Not a guess, her numbers. Every medication tied directly to her labs and recovery stage. Ibuprofen because her CRP is 2.8. BPC 157 for tissue repair at excision sites, not a generic post-op list. Her protocol updated in real time. The endocare module tracks Lillian's recovery phase day by day. Every milestone, every check-in, every symptom log, all visible to Dr. Osias before the next visit. Ask Lily anything about Lillian's care, progressive recovery, medications, or what to expect next. This is live. Lily has Lillian's complete clinical context. Everything Lillian asked Lily, summarized and ready for Dr. Osias. Questions asked, clinical findings, recommendations. 1 click to approve and add to chart. Lily detects a critical symptom pattern. Patient and surgeon are alerted simultaneously. 0 lag between detection and action. This is what Dr. Osias sees this morning. Lily flagged Lillian's ferritin, drafted the follow-up, prepared the visit brief. Dr. Osias walks in already knowing everything. 1 surgeon, 10 times the patient capacity. Lily drafted this refill reminder for Lillian automatically. Dr. Osias reads it, edits if needed, approves in 1 click. No NP writing drafts, no patient waiting 2 days, 0 administrative overhead. Dr. Osias speaks. Lily transcribes and fills the right fields, notes, prescriptions, follow-ups, all from 1 recording. The entire visit is documented before she leaves the room. Every record Lillian uploads in her portal, synced here instantly. AI extracted, diagnosis, medications, key findings. Dr. Osias never asks for records that are already in the system. not instead of their surgeon, alongside them. Every symptom, every lab, every question, 24 hours a day.
Yeah, so the way, I know we don't have any time, but we, basically the way you design this is you would have.
Really? Sorry.
Sorry.
So don't look back, anyone. I'm just kidding. Hi, I'm Isha. I'm working alongside with Dr. Osias and Lily to build this AI prototype. I'll just stand for everyone. Hi. So I'm just going to do a live interactive session with this AI that we built. Lily's going to share her surgery date. It's not going to take more than 30 seconds. I know we are.
Can we do, maybe we could do this at the Q&A. We have one more speaker and then we could segue to this.
I will follow the lead, whatever you guys
Yeah.
want.
We're just 6 minutes behind.
Oh, okay, no problem.
Stay on task. We'll have one more speaker, Dr. Simon, and then we could segue to this and questions. Thank you. Maybe we don't have any more speakers. Okay, great. So now's the time.
Hold on.
I'm so sorry.
Oh, we have pre-recorded video. Here we are. Here's our pre-recorded.
And congratulations for this outstanding Congress. And I'm so proud that you are working even with me in a consensus conference to deal with endometriosis and gynec cancers in a global consensus. So next time I will be in your wonderful place, and I'm really, really happy to talk with you now about the truth behind uterine tumors and to separating myths and facts in myomas and leiomyosarcomas. And I'm so proud that we can start the dialogue, because I think there's no other diseases where we see so different diagnosis under the title of sarcoma. And I want to mix one side the topic of myoma to discriminate, but even to ask how is the clinical sequelae after we did morcellation, for instance, because we have not been aware of the presence of leiomyosarcoma. We will talk about sarcoma. We will not talk about cancer sarcoma, because I'm always wondering why some of the patients are still discussed in the MTD regarding sarcomas with a diagnosis of cancer sarcoma. Cancer sarcoma are in general a very aggressive tumor type based on the aggressivity of the epithelial component. And that's the reason that if you talk about cancer sarcoma of the uterus, you have to look on the phenotype of the signature, what we use now in endometrial cancer, p53 mutation. What's about the microsatellite status? What's about the POL mutation? What's about estrogen and progesterone receptor? So that's are the information you need. And so I like to separate this topic from leiomyosarcoma and other sarcomas, because they again epithelial diseases. So I'm from the Charité, from the campus Virchow Clinical. Rudolf Virchow was one amazing person. He was a politician. He was an anthropologist. He was a doctor. He was pathologist. And he have observed that even myoma or sarcoma are different diseases. And you know the huge variability of the phenotyping of fibroids. And the question always is, can we discriminate between fibroids and sarcomas? I'm happy to be part of the European guideline, and you see that it's really important to look on the symptoms. Bleeding is one of the key issues, and even to learn how we can examine by using the ultrasound, and want to underline that most of the pelvic organs can be optimal described by vaginal and abdominal ultrasound. And so what is even a key discriminator is the pre and the post-menopausal status. And that's the algorithm we suggested. And based on our guideline, it's really important that even if you look on Doppler transvaginal scan as additional information, and that we even look that in case of uncertainty, then you can add the MRI, for instance. But again, most information can be received by vaginal ultrasound. I just had a patient, young woman, 25 years old. And the question was, is it maybe a suspicious for leiomyosarcoma? And in this case, I did a biopsy, and and we will touch the topic of forcilation, we are always afraid to do like a fine needle biopsy. But in this case, I think it's much better than to make a hysterectomy in this young woman. And so far, there's no hint that you will compromise the overall prognosis of the patient. Think about the discussion many years ago that we touched the topic of biopsy in case of breast cancer. So I'm strongly recommend in case of unclear uterine formulation that you will do a biopsy. So what is a normal size? Because most of the guidelines have removed the recommendation that if you see a patient with a multiple growth in size of the fibroid, to do a hysterectomy immediately. So this is one study from our center, but there are several much more. And you see, especially in the size between 2 and 5 centimeters, many of the fibroids are growing without the result of being a sarcoma. So using only the size is not acceptable to do a surgical intervention. So it's much more. But if you see a woman in a post-menopausal status, I think then it's a different case. And yet, in this case, you have to be much more aware about this. So, but to repeat it, a normal growth is not really the key, and you see the key driver for the treatment decision-making process. What's about biomarker? We know that if you have a very aggressive proliferative diseases, then you can see a high increase of the lactate dehydrogenases, the LDH, what is a surrogate marker for proliferation and inflammation in the human body. And I can tell you, we use it as additional information, but I have even seen patients with a high tumor load, with metastatic lung, with normal LDH. It's not a biomarker like CO125, where you see a dynamic in high-grade ovarian cancer, for instance. But additionally, we use it. Secondary, what we look is anemia, especially if you don't see a bleeding, and you see a patient with anemia, that can increase the risk that it's not a fibroid, it's a sarcoma. And what we also look is to look on reticulocytes as a pre-surrogate marker for anemia and to check ferritin, transferrin, and these are additionally. CO1 to 5 is generally in fibroids, especially if they have a contact to the peritoneum surface, a higher concentration. And generally it's about 50, 100, 150. In generally, it's not higher than 300. But if you have patients with endometriosis, for instance, especially if the diaphragm or the upper abdomen is affected, then you can even have much higher levels of CO1 to 5. But we use it even in case of leiomyosarcomas as an additional information. But it's not black and white. So, and it even depends on the tumor pattern of the fibroids. It's more retroperitoneal, like interligamental, it's much lower than if you have big fibroid in case of ascites.
And what we can only recommend, if you have a biomarker, if you have a fibroid, and you look on the patients further after 4 or 6 weeks, then you can use the biomarker to see the dynamic of the diseases. So it's more the awareness.
And the knowledge. Sarcoma are seldom, but they are. And even have much higher levels of CO1 to 5. But we use it even in case of leiomyosarcomas as an additional information. But it's not black and white. So, and it even depends on the tumor pattern of the fibroids. It's more retroperitoneal, like interligamental, it's much lower than if you have big fibroid in case of ascites. And what we can only recommend, if you have a biomarker, if you have fibroid, and you look on the patients further after 4 or 6 weeks, then you can use even the biomarker to see the dynamic of the diseases. So it's more the awareness.
I think the slides are repeating here.
And the knowledge. Sarcoma are seldom.
I think we should stop it, please.
And this is a patient with cervical cancer. She was treated by radiochemotherapy. And then she came back with ascites and just no cervical cancer, squamous cell cancer, in general, have no carcinomatosis. If they have carcinomatosis, then it's generally dry. But in this case, it was huge fluid in the abdomen. So I did a laparoscopy. You can see it's a diagnosis of angiosarcoma based on the post-radiation effects. This is a patient who have a neovaginal and a neolabial because she changed the gender, and it was epithelial sarcoma, and we have been consulted because the margin was not free of diseases, and so we did second surgery. So this is a patient with a synovial sarcoma. Synovial sarcoma are not based on the joint. It's based on the phenotype, looks like joint tissue. But this origin was uterine. And this makes the differences that we, in case of fibroids, it can be associated, it can be maybe induced, similar to endometriosis. Not every endometriosis, in case of cancer, is the reason or the cause of cancer, but some of them, yes. And this definition is not ready in the pathological terminology. And you can see even this case that in most of these cases, lymph vessels are not affected, but in this case it was affected, but only on the mesometrium. And you can see this phenotype of this synovial sarcoma is very similar to what we know from fibroids. So this is a patient with leiomyosarcoma. She was postmenopausal, and you can see that we did the surgeries on block resection because morcellation in this case should be always avoided, not to diminish the prognosis. And you see our anatomic specimen, the high amount of fibroids, and that's the reason why it's so solid in these diseases, and that's different. So it's postmenopausal. If the patient's pain, like hydronephrosis, or the patient's anemia, and it's monocentric, then the risk that sarcoma is present is very high. So this is a patient with the same specimen with the high amount of fibrosis. This is a patient, she is a nurse, and she was referred to me to make a complete resection in case of high-grade ovarian cancer. But during the surgery, I mentioned this is not a typical high-grade ovarian cancer because it was very fragile, bleeding immediately. And this surgery is now 10 years ago. There's a diagnosis of a malignant peritoneal leiomyosarcomas after a supracervical hysterectomy by morcellation. And I can tell you the truth, the patient is still alive. She underwent relapse 8 years later in the oligometastatic diseases, and it's still, without any subsequent treatment, she is still alive without cancer progression. So this is a patient, 47 years. She was known with multiple fibroids, but suddenly it grew up, and the doctors in the other center, what's maybe not a center, did the embolization. And they're wondering it's not growing down. And we did surgery on this, and you see it's a leiomyosarcoma. And if you ask me now in which multiple fibroid the leiomyosarcoma is, and there are studies showing you that mostly if you have multiple myomas and if you have a leiomyosarcoma, it's always in the largest or in the second largest fibroid. So this is even, I think, important. And you can see even again the phenotypes of these different buccal fibroids, and this was a leiomyosarcoma. And that's the reason that size doesn't matter, but if it's period postmenopausal with secondary signals to have a cancer or a sarcoma, then you should be very aware. So we analyzed the data from the German registry. I will show you even our Shirazian registry of sarcoma. And because in some of the communities, they believe that women sarcoma are always the same as men, but that's not true. And as a gynecologist, I will always underline that this is really different. So that there are differences in prognosis. So we have leiomyosarcoma, but we have also stroma sarcoma. You know, high differentiated and low differentiated. So high differentiated are generally mostly diagnosed at early stage with a bleeding, and they are generally estrogen progesterone positive, and the prognosis favorable. Undifferentiated stroma sarcoma are different and can even have advanced diseases in higher stages. So when I show you now the morcellation, you know, I tell you in Europe, in Germany, they are still many believers that you can do marsullation without compromising the patient is fake news. And I can tell you, even this graph is just submitted to the International Journal. Even in women postmenopausal, many of the doctors in Germany doing marsullation or supracervical hysterectomy, and I think this is really a shame. Yes. And you see, most of the women had several bleedings. And you know that abrasio is not the adequate diagnosis because not all of them touching the cavity. And you see that I think we agree in these cases, you should avoid any type of marsullation. And I think this is the story. And even to think, if you have a marsullation, that you can compensate the negative prognostic factor by using a chemotherapy is wrong. Because there's no efficacy so far using adjuvant chemotherapy to compensate the low prognosis for these patients. And we analyzed our patients. You can see that in most cases, you see the event of death within the first 3 to 4 years. So follow-up measurement is very important, despite the fact that we have no evidence if you have a relapse after marsullation, and even if you detect this diseases earlier, that this patient will live longer. So this is my key message. And you see, it's not only for leiomyosarcoma relevant, it's also for stromosarcoma relevant. And this is the conclusion that if you have a suspicious fibroid or tumor in the uterine cavity, it's better to make an expert ultrasound and even to send to expert centers. From my personal perspective, it's a gynae cancer center and the sarcoma center, what works very close together. So this is our definition. So I just answered in the beginning, it's awareness. I don't know if you can see the gorilla in the slide. It's taken by a publication in the New England Journal. So very well-trained radiologists, only 20% of these colleagues have identified this gorilla. They describe the heart, they describe the lung, but they have not seen the gorilla. And that's, I think, is a message. Sarcoma are seldom, but they are present. And that's the reason we have to be aware, to train, to inform, and to educate our doctors. So again, 1,000 thanks for your wonderful congress. I'm sure that we will meet each other very soon, and I invite you for our Charité Mayor conference this year, digital. It's for free, and we will discuss the hottest topics in gynecology, and you are welcome. Thank you very much for your invitation.
Okay, we are running behind on time, but if we have just 2 questions in the audience, anyone with a question they'd like to ask?
This is a question for Dr. Osias. I use BPC 157 a lot in my practice, especially for autoimmune disorders and decrease inflammation, but after a few years of follow-up and discontinuing BPC 157, I see recurrence of the issues that they had in the past. I was wondering if you see recurrence after you stop BPC 157 in patients with endometriosis.
Thank you very much for that question. Well, what we're doing right now is that we're just using BPC 157 in isolation. So that's why we do the complete workup to look at what we can do to decrease the milieu in which endometriosis occurs. So people might have that concern because BPC 157 does improve one of the things that does improves blood flow, so they might have concern that in the setting of an estrogen-sensitive tumor, that if you use a modality that might increase blood flow, does that increase the likelihood of recurrence? But what I find is that if you help with estrogen detoxification, and if you implement your therapies as part of a broader context, so we use BBC 157 orally, but we also detoxify with things like diindomethane or other phytonutrients that help with estrogen detoxification, so you're just not using BBC 157 in isolation. So I generally don't have any patient I addressed on DPC. I think of it like if we're using more natural therapies, it's gonna be like having a salad. You don't just have a cucumber in your salad, you tend to have tomatoes and other ingredients. So I tell them it's gonna take a lot more ingredients, but focusing on healing the gut. So I try to heal the gut by not just by BBC 157, we use other modalities like larazotide, which is being studied now by Dr. Alessandro Fasano at Mass General, who looked at that in patients who have celiac disease, that they have increased intestinal permeability. And similarly, patients with endometriosis have the same pathology. So we try to heal the gut and help lower inflammation. And in that setting, I think they do better. But that's something we're going to be able to do, because that AI tool that we're developing for Dr. Najat is we're going to be, because we're trying to integrate our care as part of the medical care and the alternative modalities. They have to talk to each other. So the AI tool is going to help us do that. To also stay relevant, because otherwise we're always functioning in silos. You know, so Dr. Najat does this perfect surgery, and then they come to me and I recommend all this stuff, and then how come the system doesn't talk to each other and the patient doesn't have a clear roadmap? So our goal, we're going to be able to answer that, because we're doing the research right now to be able to understand prospectively what does it mean to use these modalities in terms of likelihood of recurrence. So that's a very good question.
Okay, any other, one more?
Hi, my name is Shreya. I'm a high schooler from the Bay Area, and I'm actually presenting a poster here. So I had 3 questions, but I'll only ask one. So, this is for Dr. Shirazian. So I think earlier in the session, the topic came up that women in the US, they're less likely to take hormone treatment or take hormones compared to outside. I was wondering, in your AGCES study, or expanding, if you're looking into expanding education into options for women and hormone treatment, etc.
Yes, so are you referring to the FACT study or the script counseling study?
I guess both of them.
Okay. So yes, I think medication management and alternative management is a huge part of what we do at the Center for Fibroid Care. So the script study, where we've actually tailored these video scripts for providers, we do talk a lot about medical management. We talk about GnRH antagonists, we talk about progesterone, we talk about all forms of medical management. And I do think that should be a central part of what we discuss with our patients, because layering in all these various forms of treatment are very, very important. I think it's amazing that you're here as a 17-year-old and starting to learn all of this material and learning about women's health. I think it's just so wonderful. And the FACT survey, we asked women about what options they've been given. In fact, most women across the country are just put on birth control. So I think there's a huge stigma around birth control, because many women at least in the US, from our experience, from our research, have been told, you just should go on a birth control pill. It'll be fine. Don't worry about it. You don't need to do anything. Just take a pill. And I think that language and that counseling and that sentiment has to change. Maybe a birth control pill could be useful in some contexts, but understanding your underlying health needs and how your body works and what the issues are is very important when we encourage women to start any kind of medication. So I think the pendulum will swing away from that birth control pill just to offer a lot of other medical management options. All right. Well, we have the Lunch and Learn next. So please join us at the Lunch and Learn. Thank you.